All right, hello everybody. Now we're going to get into chapter 5, which is antibiotics. There's a lot of information in this chapter, but it won't be too bad. All right, we'll get going. So we're just going to start with a brief introduction, some terms and things that we need to know. The first one is antimicrobial. So antimicrobial is a broad term that applies to several different categories of agents. These are antibacterial, antiprotozoals, antiparasitic, etc. Because bacteria are the cause of surgical site infections, antibacterial, or the more common term, antibiotics, are the most commonly used agent in surgery. Okay, the most commonly used are the antibacterials. The CDC estimates that 30% of all hospital-acquired infections are attributed to SSIs. Okay, an SSI is a surgical site infection. It's an infection that occurs at or near the surgical incision within 30 days of the operation. And that can expand to 1 year of the operation if an implant is involved. Most SSIs are caused by 6 types of bacteria, which are listed in Table 5.1 on page 67. Where the most common of those 6 to cause SSIs is Staphylococcus aureus. Okay, antibiotics are used to supplement sterile technique, never replace it. Okay, SCIP, which we have talked about several times before, aims to reduce the occurrence of SSIs and improve compliance for proven effective measures related to antibiotic use. We also have the surgical patient checklist, which helps ensure compliance with antibiotic use. And where do antibiotics come from? They come from fungi and bacteria. An example is penicillin, which comes from Penicillium chrysogenum, and bacitracin, which comes from Bacillus. SSIs are caused by the introduction of a pathogenic microorganism into a susceptible host. So the pathogen must have a source, a means of transmission, and a susceptible host to cause an infection. The source of a pathogen may be endogenous or exogenous. Endogenous means that it comes from the patient's own bacteria, such as Staph aureus, which is a natural flora on our skin and nasal cavities. If it's exogenous, it comes from outside of the patient, such as surgical personnel, the surgical room, the environment, or even improperly washed or sterilized instruments. And 2 common methods to identify pathogens are the Gram stain and the culture and sensitivity, which we will go over. So before we talk about those, we need to cover a little bit about spectrums of antibiotics. So we have the broad spectrum antibiotics, which cover a wide range. They have a wide range of activity. They are effective against gram-positive and gram-negative stains and bacterium. Then we have the narrow spectrum. These are a smaller range of activity, and they're often effective against one category of microorganisms, such as gram-negative or gram-positive. And then we have the limited spectrum. Limited spectrum antibiotics are usually only effective against just one species of a microorganism. Those are the limiteds, just effective against one species. So a broad spectrum antibiotic is given to begin immediate treatment while awaiting the results of gram stains and culture and sensitivity. So gram stain is a rapid identification test that assists the physician in prescribing the appropriate antibiotic. And there are ways of distinguishing types of bacteria in combination with morphology, which is the study of shapes. So bacteria come in many shapes, but there are 3 major groups, and those are listed in figure 5.4 on page 68, usually rods, spheres, and cones. Okay, and then the culture and sensitivity. This process takes a little longer. It's the process of growing microbes in a culture to determine the infecting pathogen, and exposure to different antibiotics to determine which one inhibits that pathogen's growth. So as you can imagine, this takes a little bit longer, whereas the gram stain is a rapid identification. So for the culture and sensitivity to be performed, Tissue or fluid sample needs to be obtained from the patient. Separate culture tubes are available for aerobic and non-aerobic cultures, which, if you'll remember from your past microbiology, means either oxygen containing or non-oxygen. So in the lab, the plates are inoculated, which means that they are introduced with the pathogen, and then they're incubated for 24 to 48 hours. Once the microbe is identified, it's then exposed to different antibiotics in the sensitivity portion of this. And once the proper antibiotic is identified, then more treatment can be added to the patient along with that broad spectrum that they're already taking. And to be effective, antimicrobial agents must have selective toxicity. So selective toxicity means that it must act against the pathogenic microbes without harming the host cells. So bacteria are one-celled organisms. They don't have a fully developed nucleus, so they are called prokaryotes. Multicellular organisms like plants, fungi, and animals, these are known as eukaryotes. Okay, we do have a fully developed nucleus. Prokaryotic cells have smaller ribosomes that are responsible for protein synthesis. And so this size difference offers an avenue of action for antibiotics. Antibiotics do not bind to the larger ribosomes of the eukaryotes. They do bind to the ribosomes of the prokaryotes because they are smaller. And that's where that avenue of activity happens in that selective toxicity. Okay, antimicrobial agents work against pathogenic microorganisms by 5 different mechanisms, and you can see those listed in box 5.1 on page 70. The antimicrobial agents are they're classified as bactericidal and bacteriostatic. So bactericidal will kill the bacteria, and this includes the aminoglycosides, cephalosporins, and penicillins, all of which we will go through. And the bacteriostatic agents inhibit bacterial growth, and then they rely on the host's own immune system to take over from there. And this includes our macrolides and our tetracyclines. They can also be classified by their spectrum of activity, which we went over, the broad, limited, and narrow. Okay, so we'll talk a little bit about antibiotic resistance here. Approximately 70% of bacteria that cause hospital-acquired infections are resistant to at least one of the treating agents that we're using. So antibiotic resistance is the ability of some pathogens to withstand the activity of antimicrobial agents. Some of them do this by bacteria that can obtain resistance through conjugation or joining together. And thus they share their DNA in segments called plasmids, and this can help them to develop that resistance to antibiotics. So there are 4 major categories. The microorganism may manufacture microbial enzymes that inactivate an antibiotic. The cell membrane can be altered to prevent the antibiotic from entering the cell. The target area, such as the ribosome, which we just talked about, may be altered so that the agent is no longer effective. And a microorganism may add a substance to the antibiotic that inhibits its ability to reach its desired binding site. Okay, some bacteria produce an enzyme that is called penicillinase. This enzyme breaks down part of the chemical structure of penicillin, and it makes it ineffective. It's produced by a number of microbes, including 2 common strains of staph. When an antibiotic resistance appears as a bacterial trait, then pharmaceutical manufacturers have to develop a new form of the antibiotic that's capable of withstanding the bacterial resistance. An example is methicillin. It was developed to treat some gram-positive pathogenic microbes. A strain of Staph aureus developed a resistance to it, and we know that as methicillin-resistant Staph aureus, or MRSA. Methicillin is no longer used clinically, but the term MRSA is still used to represent the Staph aureus strains that are resistant to all penicillins. And we also have vancomycin-resistant enterococci. So this VRE digestive tract bacteria has developed a resistance to vancomycin, which is commonly used in surgery as well. So pathogenic microorganisms are continuously being identified. Microbes are capable of developing resistance mechanisms faster than the scientists can develop new agents. So as you can imagine, this is an ongoing battle that we will probably be fighting for quite some time. It's linked to the misuse of antimicrobial agents, for instance, inappropriate prescribing. A lot of times we may prescribe an antibiotic for a common cold, which is a viral infection. Antibiotics are not effective against viral infections. And not taking the necessary antibiotics as prescribed, that can also lead to a resistance. For instance, if you don't finish an antibiotic and take it as it was needed or as it was prescribed to you, that can build up a sensitivity, and it can build up that resistance to the antibiotic. Okay, so let's get into some specific antibiotics and medications. We have the beta-lactams. This is a large class of antibiotics. They're similar in chemical structure, and they contain a structure known as the beta-lactam ring. All drugs in this class act on bacteria by inhibiting transpeptidase, which leads to the formation of very weak cell walls that are really vulnerable to rupture. Most of the agents in this class are not effective against MRSA. And there's three major groups of antibiotics in this class: the penicillins, the cephalosporins, and the carbapenems, which we will go over individually. So we'll start with the penicillins. This is the first of the true antibiotics. It was discovered in 1928 by Alexander Fleming. And if you read the Insight 5.5 on page 73, it's a pretty interesting read about how he discovered the penicillin and how it came about. It was originally extracted from mold, Penicillium, and it's now available in several different natural and semi-synthetic forms. It is effective against a wide variety of gram-positive and gram-negative microbes. There's 4 basic categories available: natural penicillins, penicillinase resistant, aminopenicillin, and broad-spectrum penicillin. Okay, penicillin can be given orally, IM, or IV. And it is good to note that allergic reactions are common with penicillin, usually mild, but they are pretty common. So the natural penicillins include penicillin G, penicillin V, and penicillin G benzathine. These are low cost and they have a low toxicity. They're relatively narrow spectrum of action, so they don't cover a whole lot of things. The penicillinase resistance include naphthacillin and oxacillin. These are semi-synthetic. They're developed to be effective against bacteria that produce penicillinase. MRSA is resistant to all penicillinase-resistant penicillins. The aminopenicillins are ampicillin and amoxicillin, which is a pretty commonly known one. These are chemically altered by adding an amino group to them, which makes them effective against gram-negative microbes. And then finally we have our broad-spectrum penicillins. These include piperacillin and ticagrelin. Both are effective against Pseudomonas. These are semi-synthetics that have been chemically altered to be effective against gram-negative microbes as well. Okay, now we move on to our cephalosporins. These are broad-spectrum antibiotics. They're derived from the fungus C. acremonium. They're used as prophylaxis in a variety of surgical procedures. In fact, it is recommended as a part of the skip procedure. It's given orally, IM or IV, and it can also be given as a topical irrigation during surgery. It's classified into 5 different generations. Each newer generation has a greater gram-negative property and a longer half-life, which means the doses are needed less frequently. Okay, so in our first generation, these are active against many gram-positive and some gram-negative microbes. The second generation is effective on a wider variety of gram-negative, but fewer gram-positive microbes here as well. In the third generation, we have a wide range of activity against gram-negative microbes, but they're less effective on the gram-positive microbes, and these are usually used in treating the hospital-acquired infections. The fourth generation is an expanded spectrum on both gram-negative and gram-positive microbes, and many can cross the blood-brain barrier, so that makes these effective against meningitis and Pseudomonas. And then we have the fifth generation. The FDA has only approved one agent, and that's Teflaro, effective against MRSA and VR Staph aureus, acute skin infections, and community-acquired bacterial pneumonia. That is what we are using this agent in. All right, we have the carbapenems. These are beta-lactam antibiotics with a wide spectrum activity. They do act against gram-positive, gram-negative, and anaerobic bacteria. And they're indicated only really for serious gram-negative infections, especially the polymicrobic infections, which means there is usually more than one or two microbes involved. There's several different ones. We have the monobactams. This is a very, very small class of drugs. There's only one actually, and that's azactam. This is a totally synthetic form of an antibiotic that was originally isolated from Chromobacterium violacum. It's used to treat infections caused by gram-negative bacteria. That does include Pseudomonas. And it is safe to use in patients with allergies to other beta-lactams because of its slightly different chemical structure. And this is usually given IV or IM. Then we have the aminoglycosides. So bactericidal actions are attributed to two mechanisms with these. Okay, they interfere with protein synthesis by binding to bacterial ribosomes, which we've talked about earlier. And they create small holes in the bacterial cell membranes, which cause leakage, thence killing the bacteria. It's active only against aerobic gram-negative bacteria and just a few gram-positives like Staphylococcus. And this does include some of the methicillin-resistant strains as well. There are some major adverse effects that go along with aminoglycosides. That includes nephrotoxicity and autotoxicity. In fact, 10% of the patients that take aminoglycosides may experience autotoxicity and or nephrotoxicity. But these can be reversed if the agent is discontinued right away. This agent is poorly absorbed orally, but it's almost completely absorbed when applied topically. IM and IV are the most common administration routes. And it's indicated for short-term treatment of serious infections like bacterial septicemia, respiratory tract infections, bone and joint infections, and meningitis and skin and soft tissue infections. And some of the common names that you may hear on these are gentamicin, neomycin, and Tobrex, which is used in the eyes. Then we have the fluoroquinolones. These are synthetic antibiotics that inhibit the DNA gyrase. So that is a protein in DNA and it gets inhibited by these. They're classified as either second, third, and fourth generation. They have a relatively low toxicity and a broad spectrum of activity, which means they are active against gram-positive and gram-negative both. Both MRSA and VRE are resistant to these. They're given orally or IV for systemic infections such as UTIs. And some of the common names that you might hear for these are Sinovac, Cipro, Floxin, and Levaquin. All right, moving on, then we have the macrolides. These include the erythromycins, so that is an easy way to remember the macrolides. These are your erythromycins. And then it also includes Zithromax, which is a semi-synthetic form. These are broad-spectrum agents as well. They inhibit bacterial protein synthesis. They are bacteriostatic for most bacterial, and bactericidal for several gram-positive bacteria, such as Legionella. They're only partially metabolized, and they're excreted almost unchanged in the bile. So most are administered orally, but erythromycin can come in a topical ointment and solution, as well as an ophthalmic ointment for local eye infections. Then we have the tetracyclines. These are the first broad-spectrum antibiotics obtained from cultures of streptomyces. Okay, they inhibit protein synthesis. Some common bacteria have developed a resistance to tetracyclines. Resistant factors are carried in plasmids, which we talked about earlier, were pieces of the bacteria DNA, and they're widely distributed among the bacteria. So these bacteria have actually developed the ability to pump the antibiotic out of the cell unchanged. So these are not widely used. They are primarily used to treat acne, and they are administered orally. Okay, next we have the sulfonamides. These are commonly known as your sulfas or your sulfa drugs. They are laboratory synthesized chemicals, and they interfere with cell metabolism. They were first introduced in 1935 by Gerard Daumat. So they are the oldest of the chemotherapeutic agents. They're prescribed for community-acquired pneumonia, unobstructed UTIs, severe burns, and some superficial eye infections. They are administered orally, topically, and occasionally IV. And they include some of the common names for them that you may have heard before: Silvadene cream, which we used for burns, Bactrim, and Septra. Then we have a few individual agents. Your book lists quite a few of them. I tried to pick out just the ones that are most commonly used in surgery. So we have bacitracin, which is used as a topical ointment to prevent and treat minor skin infections. It can be combined with polymyxin B as an ophthalmic ointment to treat eye infections as well. However, most commonly in the surgical suite, we're using it once the wound is closed. We will put some bacitracin ointment over the wound before we put the dressing on. Okay, then we have chloromycetin, which is a synthetic form of an antibiotic that was originally isolated from streptomyces. It has a potential for serious toxicity, and some adverse side effects include bone marrow depression and various blood disorders. It may be taken orally, IV, topical ointment, otic solution, and ophthalmic solution and ointment as well. Okay, then we have clindamycin. This is a synthetic analog of natural antibiotic lincomycin, and it's used to treat infections in patients that are allergic to penicillin. This is usually our go-to. If they're allergic to penicillin, we'll give them clindamycin. It does have a high affinity for bone, and so it's often used to treat osteomyelitis. And it's very effective at reducing normal intestinal bacteria as well as the pathogens. So it is good to note that the FDA has issued what they call a black box warning on this drug. Diarrhea is often, Clostridium difficile is often a side effect on many antibiotics, which the FDA puts warnings on. However, treatment with clindamycin can result in that plus severe colitis, which could be fatal. Okay, next in the individual agents, we have daptomycin or cubicin. This is a newer antibiotic. It's derived from streptomyces as well, and it's indicated for complicated skin infections and bacteremia, which is a bloodstream infection, particularly in those that are caused by MRSA. Okay, Flagyl is another common synthetic antibiotic that we use in surgery. It's administered as a prodrug that becomes activated in the presence of anaerobic microbes. It produces toxins that damage the DNA of the bacteria. It may be administered IV, and oftentimes it's given as a prophylactic antibiotic before colorectal procedures. It may also be administered IV to treat post-op SSIs, but conversion to an oral administration ASAP is recommended at that point. And finally, we have vancomycin, which is used to treat severe infections caused by MRSA. It is administered IV, and it's active against staphylococci, streptococci, and enterococci. All right, and last but not least, we have the combination agents. Colimycin S-otic is used typically to treat bacterial infections of the outer ear canal. It's usually administered in surgery following myringotomies and tube placements. We also have cortisporin otic. This is a suspension that's administered topically when an anti-inflammatory agent is needed along with the antibiotic. Remember, because it's a suspension, it does need to be shaken before it is used, and it is not intended for injection. It may be combined with bacitracin as an ointment as well. And finally, the last one that I wanted to cover is Neosporin GU irrigant. GU is for genitourinary. So this is used as a topical bladder irrigation, usually when an indwelling urinary catheter is placed. Those indwelling catheters can increase the risk for bladder infections pretty dramatically, so we'll irrigate with the Neosporin GU to prevent any of those. Okay guys, so that covers the antibiotics. I know it was a lot, but like I said, I did post this PowerPoint without the lecture narrative in the PowerPoint folders, and I will also place it in the video folder with the lecture narrative. All right, I will see you guys in just a little bit.